Hey, everybody, it's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni and Ray Pace and Dr. John Hill with us yet again. Special 5-part series for all of 24. So what we're doing is we're doing a ongoing sub-series on EMS airway management. All right, so stay tuned for this installment of EMS Airways.
I think it's warranted that we talk too about the oxygen delivery with that. I mean, if we're pumping 15 liters and the reservoir bag is full, we would expect to get quite a bit of oxygen out of it. We can, however, augment that with a nasal cannula and give a little more if we need to.
So let's double down. I want to get back to your physiology point you made about decreasing preload, right? And preparation for that. So let's make sure we get back there. But since we've worked down the oxygenation part, the augmentation of that, of course, is helpful and important, but more important is when that interval between when I take that mask off the patient's face and I'm getting my tool set up,
so you're talking about oxygen reserves.
All right, now we're talking about maintaining that, right? I guess we got to take one step back and understand that oxygenation is a completely passive process, right? I don't need to breathe to oxygenate, right? If I stopped breathing, you could just squirt air in an air hole, right? And my sats would be okay.
Yes.
Now, what's CO2? Because I'm not building up that CO2. I'm not getting rid of it. We breathe to get rid of carbon dioxide, right? Hell, it is the physiological trigger to breathe, right?
For most of us.
For most of us, right? You could just squirt air, you could squirt high concentration oxygen in me and my sats would stay fine, right?
For minutes.
So,
Tens of minutes.
Yeah. Tens of minutes, yes, absolutely. There's some very, it's real.
I get it.
The last one I read, I think, was 8 minutes. And it wasn't all that high. It was just a nasal cannula. It was all in the OR. I think 8 minutes was the average at like 6 liters. I mean, it wasn't even a tremendous amount of oxygen. They left these patients apneic and sats, average. Didn't drop, and I think 90 was their cutoff. I haven't read, it's been a while since I read that particular. And there's been several, right? But yeah, but there were some outliers that went tens of minutes and just held perfectly fine sats, right? Because they were being provided with high concentration oxygen. And the reason we ask in your airway protocols to leave that nasal cannula on, delivering that high concentration, is when you remove the BVM, right? You take that mask away, and it's that transition between, okay, now I'm going to put my King in, or I'm going to put my iGel in, or I'm going to do my laryngoscopy direct, or that patient continues, right? Even if you're
they continue passive oxygenation while you're doing the next step. Yeah, and that's built into moving into the King, moving into an iGel, moving into intubation.
Correct.
And it's just set in there as a safety measure so that they're not dropping.
Exactly. It's a safety net, right?
Yeah. And we need to know that 97 is kind of the cutoff there for SpO2. I think if you're below that, you're definitely do not have the reserves. They need to be bagged up prior to your intubation attempt. And around 100 would be good, if you could.
The other thing to keep in mind there is your pulse ox, the value you're seeing, it's not instantaneous. It's not instantaneous. There, especially in a shocked patient, that might be several minutes delayed, right? Remember, it's looking at hemoglobin and whatever digit you put it on. If I don't have blood going round and round and round well, right? How is that going to pick up, right?
SpO2 is highly inaccurate, so we dump back to what else could we be utilizing during that time? I mean, you can use if you want to passively oxygenate them, you can put them on the end tidal nasal cannula and do that same process, and we get a more accurate number. And the way I've taught in 4UH is, this is a live feed of how they are actually metabolizing that and getting rid of the byproducts of oxygenation.
It has to be on a breathing or mechanical breathing patient, though.
Correct.
So you're not going to see that on an apneic patient that I'm attempting the intubation on. You just won't. But I see what you're saying.
Yeah, you know what I mean? Versus SpO2, you're going to get a delayed thing, to your point, was kind of my tailspin into that.
I'm not a big fan, to be honest. I mean, and remember that we've talked before, I think that oxygen doesn't stop at 100%. That's where it stops reading. You can have 130% per se. You're just not going to pick it up if you're oversaturated.
So I guess let's go back to the basics. That is a percentage of hemoglobin that has oxygen bound to it, and you can have oxygen dissolved in your blood, your serum, and that's the partial pressure of oxygen inside your blood, which we get on blood gases, not picked up on pulse.
On a pulse ox. All of that goes into, the number, the pulse ox number might be inaccurate, might be delayed. Pre-oxygenate everybody. Well,
But again, have you looked at your patient?
Let's not focus on
look at the
let's not
machines.
focus on this number. It's like, oh, this number's good, so I don't have to do the thing. No, you have to do. You already kind of started down the path of how much physiological reserve do they have, right? So they can have a nice number now and then deteriorate very quickly as soon as I stop doing the thing I'm doing, right? Which might be bagging them, might be so. Is pulse ox irrelevant? I don't think it's irrelevant. You just have to know what you're looking at, right? And yeah, that says 97. That doesn't mean you can't make that PaO2 120, 130,
Right.
etc.
Yeah.
Higher than that to buy time and make a nice big safety net underneath the patient. Understanding that number might be now.
Yes.
Does my capnography let me know about the ventilatory status of the patient and, the other half of the ventilatory cycle, right? The exhalation, yeah, absolutely.
Yep.
But it still doesn't tell me anything about oxygenation. You just have to know.
And we're not doing art lines yet.
You just
not in
have
the
to.
field.
You just have to. Well, it's for pressure. It's not for. But our colleague is working through the analyzer, so maybe. But with the pulse ox, you just got to know what optics you're looking at that number with, right?
But it's good to know that, oh, my number is going up, right?
Trending, yes.
I'm bagging. We were 70s and now I'm 90s.
No, right.
Or I stopped coming off and, oh, they're starting to desat really
Quickly,
quickly.
yeah.
I don't have that reserve built up yet. I need to bag them again.
Yeah,
I
absolutely.
need to build up those reserves. If I can bag, and they're easily bagged, you might arrive, and then on report you say, I took it off, they instantly desatted. I thought it'd be best to just bag them because I can bag them.
Absolutely.
They don't, it's not required to put an advanced airway in if they're easily bagged.
And you made an awesome point earlier, Doc, that, go back to oral pharyngeal airways or nasal pharyngeals. We don't use them enough, but they work great.